And for those of you that don't know me, my name is Christy, and I'm the newest member of the marketing team here at in South Hill at VCU Health Community Memorial Hospital. And it is my pleasure to introduce Dr. Bethany Denlinger. She joined the MCV campus faculty in 1995, and she's an associate professor of internal medicine and cardiology. She is board certified in internal medicine, cardiology, and echocardiography. Dr. Dinlinger is medical director of the echocardiography lab at Community Memorial Hospital in South Hill, Virginia. And today she's going to talk about heart disease and women. Thank you.
Thank you. So if I say the word heart attack, what's the first thing that you think of? And for many of us, we think of men clutching our chests. But the purpose of today's talk is to widen your horizons, think about women clutching their chests, women having heart attacks, because heart disease is the #1 killer for women as well as men. Some of the problem is, though, women have typical chest pain, a ton of weight sitting on their chest, but they also can have atypical chest pain. They have chest pressure or this discomfort, pressure or squeezing, or they can have chest pain radiating to their neck or jaw. They can have chest pain radiating to their shoulder or back. They can break out in a cold sweat. They can have lightheadedness or dizziness. They can have nausea. They can have unusual fatigue, or they can have shortness of breath. So when somebody comes to the ER or to our office with nausea, how do we sort all this out? And we listen to their story, what makes it better, what makes it worse, but we also think a lot about what are the associated risk factors that they have, and that helps us sort things out. So that's what we'll be talking about today. We'll talk about awareness of women's heart health, and then traditional risk factors and the non-traditional risk factors. Heart disease is the #1 killer of women in the US. 1 in 3 women die from heart disease. A woman is 10 times more likely to die of heart disease than breast cancer, and Blacks are at higher risk than whites. They're 30% more likely to die from heart disease. Here's a map looking at the rates of heart disease deaths in women across the US. The highest rates are in the south central part of the US, but if you look at the southern part of Virginia, in the South Hill area, that's pretty dark red also. So it's something we need to be paying attention to. Only 54% of women recognize that heart disease is their #1 killer. They have atypical presentations. They're often sicker and older, about 10 years older when they present. And women have a longer pre-hospital delays than men due to a lower suspicion of a heart attack, and that delay in diagnosis is associated with higher death rates. Here's the anatomy of the heart. The blue blood comes back from the body, goes to the right heart through the tricuspid valves, goes out the pulmonary artery. That blood then goes to the lungs, gets oxygenated, comes back to the left side of the heart through the mitral valve, the left ventricle. The left ventricle is the main pumping part of the heart, and it goes out the aorta and takes oxygenated blood to the rest of your body. When someone has a heart attack, the heart arteries or the coronary arteries are on the outside of the heart. So if there's a blockage, and the blockage is usually made of cholesterol plaque, if there's a blockage, that pump, that artery is not, is clogged up, and that part of the heart is not pumping as well. So blood's not going out to the rest of your body. Think of your coronary arteries, throw at a baseball with your left hand. This is your left anterior descending artery, your left circumflex artery, and your right coronary artery. And each of those arteries have branches, but that's sort of how the basic anatomy is set up. But there are different types of heart blockages. We talk about the lumpy, bumpy heart blockages, or there's a focal blockage, and then there's diffuse coronary artery disease. Men tend to have more of the focal blockages, and women tend to have more of the diffuse blockages. If you go to the cath lab, it's easier to fix a coronary artery blockage that's focally stenotic. You put the catheter in, there's a balloon with a stent on top of it, you cross the lesion, and then you blow up the balloon, leave the stent in the coronary artery. The stent is similar to the spring on a ballpoint pen. That artery or that stent stays in the artery. You pull the catheter out. You take blood thinners to keep that stent open, but the blood flow is greatly improved through the artery. If you have diffuse disease, you can't treat it with a stent. You're reliant on medicines then. Women also tend to have more vasospasm, so their arteries spasm, and when that artery spasms, they get angina, they get chest pain, and then the spasm relaxes, and you treat that with medicine. Women also have microvascular disease, so that there's not blockages that we can see, but there's blockages in the microvascular area. So if you squeeze the tip of your finger and the tip of your finger turns red, that's your microvascular arteries, and that's the microvascular level of coronary artery disease. So today we're going to talk about traditional and non-traditional risk factors for heart disease. The ones on the left you all know about, and then some of these ones on the right are newer. The traditional ones are diabetes, smoking, obesity or overweight, physical inactivity, hypertension, and high cholesterol. So what happens when somebody has diabetes? You eat your food, the stomach converts it to glucose. The glucose is taken up in the blood artery. Your pancreas makes insulin. The insulin is what helps get the glucose out of your heart arteries to take it to the body, to take it to your tissues where you need the glucose. If you have diabetes, that insulin doesn't work as well, and your sugar stays high in the bloodstream, and your cells within the body are not getting enough nutrients that they need. It's important to keep your hemoglobin A1C less than 7, that's the overall sugar, and keep your fasting glucose less than 100. About 10% of American females have diagnosed diabetes. 2.5% of women in the US have undiagnosed diabetes. So that's a lot of women running around with high sugars that aren't aware of it. Diabetics may present with atypical heart attack symptoms. Women with diabetes have a 3-fold excess risk of fatal heart attack compared with non-diabetic women, and heart attacks in diabetic women occur earlier and with higher death rates than diabetic men. Smoking is another risk factor for heart disease. About 20% of US women smoke. It increases your risk of heart attack, also increases your risk of cancer. Smoking is associated with a decade of lost life, but if you can quit smoking, that reduces that loss by about 90%. If you don't quit, or if you don't smoke, don't start. If you do smoke, quit. And don't be discouraged if you're unsuccessful, keep trying. Most people that are eventually successful have tried to quit smoking several times. Also avoid others' tobacco smoke. Obesity is a risk factor for heart disease. We talk about BMIs, which is essentially your height and weight in the metric system. Your BMI should be less than 25. Overweight means a BMI between 25 and 30. A BMI of greater than 30 is the definition for obesity. And remember to do little things. Losing just 5 to 10% of your total body weight can improve your health. So don't I think one of the focuses of this talk is to try to keep on doing little things. You don't have to be overwhelmed by doing major things. Here's a chart looking at overall female obesity in the United States. The yellow is overweight. That's actually been relatively stable, but the number of women who are obese and extreme obesity is a BMI of greater than 40. Those numbers have increased in the last several years. Physical activity, move more. So our goal is either 30 minutes of moderate intensity activity 5 times a week or 15 minutes of high intensity activity 5 times a week. Moderate intensity, I would say going for a walk and you're able to still carry on a conversation. High intensity, you might not be able to carry on much of a conversation. If you can do that, also add strength training twice a week. That's ideal. If you can't reach that goal, remember that some activity is better than none. Just do 10 minutes at a time and do something that you enjoy so it's not punishment. Physical activity controls obesity, but also diabetes, high cholesterol, and helps lower your blood pressure. This chart is interesting. This just shows that if you go from doing nothing to a little bit, it decreases your risk of mortality. On the y-axis is your mortality, and on the x-axis is your amount of activity. So if you do nothing and start doing a little bit, that really drops your mortality. So again, do a little bit is better than nothing at all. Okay, high blood pressure or hypertension. High blood pressure is the single most important risk factor for heart disease. It's called the silent killer. I hear it all the time. People think that they can tell when their blood pressure is high. The only way you really know whether your blood pressure is high is to stick your arm in a blood pressure cuff. Blood pressure cuffs are pretty available. The top number is the systolic number. The diastolic is the bottom number. And then often when you get a blood pressure cuff, it also adds heart rate or your pulse. I do like arm cuffs better than wrist cuffs. I think they're more reliable. And people ask me, is systolic or diastolic more important? Both are important. It's not that one's more important than the other. Your goal should be a blood pressure of 120/80, and it really should be less than 140/90. Remember that if you take your blood pressure 7 times a day, you're going to get 7 different numbers. So look at the overall pattern of blood pressure. If one blood pressure is high but the rest are fine, I'm not going to worry about it. The other thing I would say is people say, well, I took my blood pressure before I took my blood pressure medicines. That really doesn't help me adjust your blood pressure medicines. So take your medicines in the morning and then a couple hours later, take your blood pressure and see what your blood pressure is doing. Women develop high blood pressure about 10 years after men, but then it's more prevalent and less well controlled. So what do you do if you're initially told you have high blood pressure? Watch salt in your diet. 80% of the salt is in food, about 20% is in the salt shaker. Ideally, you should be taking less than 2,300 milligrams a day of sodium. If you're on a strict low salt diet, is less than 1,500 milligrams a day. Watch your weight, improve your physical activity. It doesn't seem like it would be make that much of a difference, but physical activity does really help blood pressure overall. And alcohol in moderation, 1 drink a day for women, 2 drinks a day for men. And then take your medications. And if you, that's a whole separate topic, but if you don't like one medication, there's lots of medications, you know, talk to your provider, get on a different blood pressure medicine that works for you. Okay, so what happens when we go through menopause? What happens to our cholesterol? Well, everything goes the wrong direction. Your total cholesterol gets higher, your LDL gets higher, your HDL, which is a good one, drops, and your triglycerides drop, but then they get higher. So remember, when you're thinking about cholesterol, LDL, your aim or your goal is low, and HDL, think H is high. So your total cholesterol should be less than 200. Your LDL should be less than 70 or 100. It depends on your risk factors. For women, your HDL, that's the good one, should be greater than 50 and ideally greater than 60. And your triglyceride should be less than 150. What can we do to watch our cholesterol? Try to eat better, avoid processed meats, the deli meat, the hot dogs, sausages, and bacon. Bake or grill instead of frying. Avoid refined carbohydrates. Watch the cookies and the cakes and the candies. Avoid sugar sweetened beverages, the sodas. And also avoid salt. Salt is often in frozen meals, canned food, pickles, and chips. Think of the Mediterranean diet when you're picking food, lots of fresh fruits and vegetables, whole grain foods. Remember, the whiter the bread, the sooner you're dead. So focus on the whole grain foods. Eat lean proteins and certain fish like salmon and tuna, low fat milk and dairy products, healthy fats, the nuts, seeds, avocado, and vegetable oils. Avoid the trans fats and the saturated fats. Go for the unsaturated fats and use extra virgin olive oil. And again, soft drinks have a lot of sugar in them. Try to avoid those. And even the diet sodas, I'm not sure that they're that much healthier. So really just drink water. Okay, let me talk about the non-traditional risk factors for heart disease, the things that we usually don't think about. And the first three have to do with pregnancy, high blood pressure during pregnancy, diabetes during pregnancy, and preterm delivery. And then we'll talk about autoimmune disease, breast cancer treatment, and depression. So hypertensive pregnancy, that means your blood pressure was fine before you got pregnant, then you had high blood pressure as you were pregnant. If you have preeclampsia, that includes protein in your urine, and often people drop their platelets a little bit, and then you deliver the baby, and then the blood pressure goes away. Gestational diabetes is the same, pregnancy or diabetes during the pregnancy that gets better after the pregnancy. Preterm delivery is delivery less than 37 weeks. A normal pregnancy is 40 weeks. Small for gestational age, so a small baby is a risk for future cardiovascular risk later in your life, and recurrent miscarriages, 2 or more, is a risk factor for future cardiovascular risk. So think of pregnancy as nature's stress test on the heart. There are times in our lives where our bodies aren't behaving the way they should, and we should pay attention to that not to give up, but to pay attention that everybody needs to eat right and exercise and take care of themselves. But these women should pay a special attention to that. So here's a graph. The green line is vascular dysfunction. The red line is a woman with abnormal pregnancies, and the blue line is a woman with normal pregnancies. So the woman has her first pregnancy. She crosses over that vascular dysfunction line, which means she's at risk for maybe high blood pressure or trouble with her arteries. She delivers the baby, the risk goes down. She has her second pregnancy, level goes up again, delivers that baby, level goes down. But when she reaches middle age or later in life, she crosses that line for vascular dysfunction, which means she's at an increased risk probably for heart attack or stroke earlier in life than the woman who did not have any trouble during her pregnancy. So the goal is to pay attention to these women with abnormal pregnancies, and if we can do lifestyle modification, watch their sugar, watch their high blood pressure, keep them exercising, keep this risk factor lower, and keep them under this line of vascular dysfunction, and so they don't cross that line until later in life, more in tune with the women who had normal pregnancies. And this is, there are different times in a woman's life when she crosses this vascular dysfunction line. In the middle is what I just talked about, but also before pregnancy, if you start periods at an early age, have polycystic ovarian syndrome. I'm not saying that hormone contraceptive use is bad, but if a woman has high triglycerides to begin with, some birth control pills exacerbate the high triglycerides. And then at the other end of the pregnancy, if you go through menopause at an early age, all of these things can be associated with an increased risk of heart disease earlier in life in the future. So think about it as times to intervene, not to be depressed, but just to make sure you're taking care of yourself. Other non-traditional risk factors, autoimmune disease, which includes lupus and rheumatoid arthritis. Now, rheumatoid arthritis and lupus are not unique to women, but they are more common in women. And those diseases are associated with a 50% higher risk of heart disease. And breast cancer treatment is also associated with a higher risk of heart disease in the future. Radiation, especially if it involves the left breast, they can have accelerated coronary artery disease 20 years later. In chemotherapy, the adriamycin and Herceptin chemotherapies don't cause coronary artery disease per se, but they can both cause heart failure. So things to pay attention to. And lastly, stress is associated with future cardiovascular risk. Try to de-stress, take deep breaths, get enough sleep, 7 hours of sleep a night. Find something that calms your brain for at least 10 to 15 minutes a day. Take a break, connect more. Loneliness is associated with poor health. and depression makes it difficult to maintain a healthy lifestyle and follow recommended treatment. Let me talk a little bit about the effects of the COVID. This is an interesting graph. They took patients who had defibrillators in New York City and looked at their activity before COVID and then after the stay-at-home order. And clearly, the activity has decreased as COVID hit. And I don't think we, whoops. Hang on a minute. I just blanked out. I don't think that anybody's surprised by this. During COVID, we've become less active. A lot of people have gained weight and we're more socially withdrawn. We're depressed, we're frustrated, and sad. So I think even, and I don't have any great recommendations, but even though if you haven't had COVID, COVID has still affected our risk for cardiovascular disease. And so it's important for us to, try to keep on doing little things. Stay as active as possible. The weather's been terrible, but now today is much better. Get outside, take a walk, eat your fresh fruits and vegetables, make a phone call to somebody you care about, and try to keep on plugging along, even though COVID has been very frustrating for all of us. And that's it. Any questions?
If you would like to ask a question, you can either unmute your microphone or you can type in the chat.
I have a question.
Sure.
So are there any other, are those the only, you mentioned autoimmune disorders and you mentioned specifically lupus and rheumatoid arthritis. Are those the only ones that have an increased risk with heart disease, or do others as well? So I've had a lot of psoriasis. I'm taking some an immune suppressant now for that. And I am seeing a cardiologist because I know in general I have increased heart issues, but I didn't know if that as an autoimmune disorder, if that had an impact.
I think the best studied are rheumatoid arthritis and lupus. I suspect all of them have some effect. I think it's important for, I think other ones have an effect also, other autoimmune diseases.
Thank you.
Yep.
And we have a question in the chat that says, define early menopause, please.
I think it's less than 50 and less than 45. I think premature ovarian failure is less than 45, and early onset menopause, I think, is less than 50. I'd have to double check.
Question.
Yes.
Yeah, I'm real curious about this. As I went through the whole presentation, I have none of the risk factors, like none. No family history, none of the things on the list, except I am a breast cancer patient. It's almost 8 years, so it's like really good news. But I asked my oncologist last week about the medicine, the effect that my chemo might have had, and he felt like what he used for me was probably not a factor. I do know that when you got to the COVID part, I thought, this is why I'm here, because with no risk factors, I did end up last week. I was having like weird heart kind of palpitation things, and I did end up with an abnormal EKG, which the doctor was shocked. My PCP was shocked because I have no other risk factors. And so I do have a scheduled appointment because she found the the left branch block thing I can't remember all the letters. It's 3 B's, I know that. And so I'm curious because I know that I am very stressed and I know that I've been really depressed, but my reason is not from lack of exercise. I have continued through this entire year. I've always exercised, and I've continued to walk at least 5 miles a day. And so even with the gym closed, you know, I have to go outside and walk. So I'm just really curious as to what you think the percentage of actual stress or depression is in the factoring into this heart issue. Because that was really curious when you got to that. I thought, wow, there we go.
Not sure I know a number. I think it plays a role. I think there is a lot of depression, and I think I think that's one of the hard things that, that COVID has brought on, that there is a lot of, mental stress, but I don't know any numbers.
How does that translate to your heart?
Your blood pressure is higher, your adrenaline's higher. It's just,
What if my blood pressure is always low, like low, like usually maybe 115/65 average? It never goes much above that.
I suspect that you're still probably low risk. Well,
it was just weird because I kept checking, nope. And then we finally got to the last one, which was really the only possibility, I think.
Mm-hmm.
So, well, that's good to know. I really appreciate the information.
I just wanted to add something as far as exercise. Just as a suggestion, what I have found that has really been helpful to me and motivating is I have a Fitbit. And it keeps me motivated to exercise and also allows me to kind of monitor my activity and my heart rate. And I have a dog that I walk regularly, and like the lady that just spoke, we walk 5 or 6 miles a day. And then the other thing that I do as far as fitness, I don't do weight training per se, but I do yoga. And I find that to be really helpful and in a lot of different ways. De-stressing, it's a little bit of strength because of the moves that you make, and flexibility and balance. So those are things that have helped me try and keep going. And especially on Fitbit, you can get a buddy that's on Fitbit and kind of keep each other going. So I just wanted to add that comment.
Great, thanks for sharing. Yeah, I like the competition of Fitbit. And yoga and core training and all that stuff is, I think exercise is 50% physical and 50% emotional a lot of days. It's important to get out and get moving for mental health as well as physical reasons.
You all have had some great questions. We have time for maybe one more.
I've had 2 ablations, one for PVC and one for SVT. Does that put me at an increased risk?
Not really. That's the electrical part of the heart, and I didn't really talk about the electrical part of the heart is sometimes related to the plumbing part of the heart, but SVT is usually not. The electrical system is in the right atrium and then goes down. It's kind of in the center of the heart, goes down the septum, and that's the electrical part of the heart. We talk about the plumbing part of the heart, which is the heart blockages. We talk about the pump part of the heart, which is the left ventricle. And then there's the electrical part of the heart, which is a different section. Now, sometimes if somebody comes in with atrial fibrillation and they have risk factors for heart disease, we'll often do a stress test just to make sure that there's not a heart blockage that's making the AFib worse or causing or related to the AFib. So they're related, but an SVT is you can have that without any other structural heart problems. And then you also have the valve part of the heart, the tricuspid valve. the mitral valve and the aortic valve. If you have mitral regurgitation, blood flow is going back into the lungs, and that can cause shortness of breath. Or aortic stenosis means that the aortic valve is not opening, blood flow is not getting out of the heart, and the left ventricle is pumping harder. So there's different parts of the heart.
Before we go, I just need to give a shout out to VCU Health Cardiology. In a really weird anecdotal thing, I was trying to get an appointment for my COVID vaccine, and somehow, after waiting on hold for 45 minutes, someone picks up the phone and says, "Cardiology," and I was like, "Oh no, that's not what I wanted." And this woman, I don't know her name, she was so nice, and she took my information, and then she just said, "You know what, we have some appointments, I can do that for you." She made the appointment for me, and I actually had my second vaccine yesterday. So shout out to really nice in cardiology. Yeah, it was good.
It was probably Kelsey Clark. She's our office manager. So
so nice.
Yep.
All right. Well, thank you all so much for coming out today. We appreciate your attentiveness, and thank you to those of you who turned your videos on. We will be posting the recording on our website and on Facebook, so stay tuned, and we'll probably be doing more of these virtual talks for you.
Thank you very much.
Thank you.
Thank you.